some like extra noise coming in through somebody, if that's all right. Yeah, you can unmute yourselves again if you want to ask me questions anytime, and you can type away in the chat, that's fine too. So yeah, this is quite an in-depth-ish view of lymphomas. There's obviously like loads of other blood cancers and stuff to look at, which often get a little bit more attention, and hopefully I or somebody else will get to teach them to you at some point soon, but this isn't to be overlooked as well, and it's actually quite simple if you really break it down to yourself. So yeah, here's a very badly drawn out version of the hematopoietic stem cell tree that I did, just because then if you've got these slides, you can look back on them, and I always find it really useful to have this to then like line up what type of cancer comes from what cell, what goes from what, and just remembering that everything, as you're looking at this image now, everything to the right hand side of the little dodgy yellow line that I've drawn, they're your lymphocytes, so they're the cells we're looking at today. Obviously, because this is all coming from bone marrow, from like those original stem cells in the first place, when one is affected, the rest generally are going to be affected as well. So like, don't forget the other types that we've got, but we're concentrating on like the NKs, the Ts and the B cells and the plasma cells today. Oh, is that Alex? It is Alex. Hi, Alex. So yeah, a little bit of a recap, because when I was going back to like making these slides for you guys, I kind of sat back and thought, I literally haven't done anything to do with this since maybe first or second year, and it is just quite helpful to know. So just remember that, yeah, this is all originally coming from bone marrow. You've got NK cells, which play a major role in destruction of infectious and neoplastic cells. B cells, which are named B for bone marrow derived. They're selected in the germinal centers of the lymph nodes, and then they produce these plasma cells, which are actively like what are producing antibodies, or they go off and they become memory B cells. And then you get T cells, which are your main ones that migrate off to the thymus, and then that's where they learn to select between self and non-self. And then you've got CD8 plus your cytotoxic killers, and CD4 plus your antigen presenting like helping cells. That's not particularly important in the context of lymphoma, just thought it was kind of good to recap. And then quick recap about the lymphatic system. So it's a large interconnected open network that returns your lymphatic fluid or your chyle back to the heart. Like main organs in this are the spleen, where you're synthesizing antibodies, and your white pulp, you're removing anything like cellular that's been coated in antibodies, whether that's bacteria or your own cells, storing this immune reserve, which is like mostly monocytes, and also like red blood cells in the instance that we hemorrhage and we need to have like some reserve blood volume from somewhere. It primarily as well is lymph nodes, which is like the part of this that's like of most concern when you're looking at lymphoma. You get this secondary lymphoid tissue, which is basically other organs that kind of act like lymph nodes. So that could be the spleen, tonsils, Peyer's patches, which you might remember from doing GI in first and second year. Any sites where you get an interaction between foreign antigens and lymphocytes. And then you can get this thing called tertiary lymphoid tissue as well, which is like more of just a bit of a fun fact that any way you can get chronic inflammation, like mostly with cancers, you can get this. So one of you, I'm going to mute again. Sorry, I feel really bad just muting you all. It's just like hard to concentrate. This tertiary lymphoid tissue is where you get these sites of inflammation, chronic inflammation. You can then get tissue that acts in the same way that your secondary or primary lymphoid tissue would. And this is kind of interesting in the context of cancer, because you can actually get areas of cancer growth where, because you've got immune cells that are actually capable of fighting off the cancers, like your NK cells that are attracted to these areas, it's a good prognostic indicator when you do have cancers. So yeah, little fun thing for you. And lymph nodes, because these are the thing we're most bothered about today. You've got about 800 or so of them in the human body. And if you've somehow managed to get all the way through med school without never seeing it before, we've got two images here for you of like where the ones in the neck, head and neck are, and like the general groupings of them in the body. And about 300 of them are located in the head and neck. And obviously where certain lymph nodes are grouped, that's going to correspond with like the organs and regions they drain. So it is, for most parts or systems of the body, it's worth knowing where those cancers would metastasize to if it was a secondary cancer. Whereas lymphoma obviously is a primary cancer of the lymphatic system. And when we say lymphadenopathy, just in case you've like, it's an easy word to just see and like forget the definition. That's loud. It just means that we've got any kind of enlarged lymph node for whatever cause. And classically in lymphoma, these are like painless, firm or rubbery lymph nodes, not like really like inflamed and sore ones like you get in an infection. And they tend to be quite mobile. And this is very easy to mistake for, say, if you've had a lot of repeated infections, you can then get scarring of certain lymph nodes. So very often you'll get patients coming in that are really worried about this one solitary lymph node they've got. And really all that just is scarring. You tend to get more like a couple of lymph nodes, usually like in one area, or a couple of areas that have like gone quite big in lymphoma. I'm just going to check any of you. Do we have any of you with questions? I might have to just check questions at the end because my laptop's being a bit of a pain. But also, like, please unmute yourself if there are, or I might just ask if Fraser can message me if there's anyone that's asking questions, if that's okay. Yeah, so moving on to lymphomas. So they are basically cancer that can arise at any site of lymphoid tissue, so any part in that system that we just talked about, but primarily they're going to occur in the lymph nodes because this is where most of like those kind of cells are housed, if you will. It's not that common, but in terms of like cases that you'll see when you're on placement and GP, etc. But it is the 5th most common malignancy of the Western world, and we tend to divide it up into non-Hodgkins and Hodgkin's lymphomas, or B and T cell. But most of what you see is going to be B cell lymphoma. And they usually present with this kind of peripheral lymphadenopathy. Patients are coming in saying that they've got painless raised lymph nodes that might just bother them due to like pressure symptoms. Because obviously if you've got say mediastinal lymph nodes, you're not going to physically notice them yourselves. You're going to notice the cough that you've got, or like the facial plethora, or like the redness, because you've got superior venocaval obstruction. So they're usually like just painless lymphadenopathy, B symptoms, and we'll get onto what that means in a minute, or just symptoms of mass effect. So the way I'm going to talk generally about all the types of lymphoma for a while, and then we'll break it down into the other types. You generally classify it using something called Ann Arbor staging or classification. And unlike TNM staging, where that's based on how many nodes or how many metastases has it got, this is just based on how many nodes is it affecting. So if it's just confined to 2 single lymph node regions, it's stage 1. Above 2 on the same side of the diaphragm, so above or below, is stage 2. Lymph node regions either side of the diaphragm is 3, and spread beyond the nodes to tissue or the bone marrow is stage 4. And then that's why in investigations coming up, we talk about like always making sure you do a full blood count, and that's just kind of to look for that bone marrow involvement. It's not as important, say, as it is in leukemia, where it's in the bone marrow anyway. And you can also use letter classification with this as well. So if someone had like Hodgkin's lymphoma stage 1A, it would mean that they don't have any symptoms, but they might have malpruritis. Or if it's B, it constitutes these B symptoms. So the B part doesn't refer to it being from a B cell. It's these B symptoms corresponding to the grade. So that would be at least 10% of your total body weight loss in less than 6 months, an unexplained fever, or night sweats. And this is generally quantified by patients saying that they've soaked through all their clothes at least once in a night. So like the things that you really need for diagnosis, obviously, like don't underestimate the importance of history and examination. People should be drumming that into you if they aren't already doing. And biopsy, because it's the histopathology of this that really like it enables us to tell Hodgkin's from non-Hodgkin's. Other than that, on paper, they're not really too different. Full blood count to see if there's bone marrow involvement, and just generally check how the patient's doing. ESR, this is an inflammatory thing, it's going to be elevated. LDH, lactate dehydrogenase, is always elevated in instances where you've got increased cell turnover, and generally like the higher it is, the more of a poor prognostic marker it is, unfortunately. You want to do a blood film as well, because you're looking to see if it could be any of your other differential diagnoses, which are like your other leukemias and infectious causes like Epstein-Barr virus, HIV, things like that. Chest x-ray, look for mediastinal widening. We've got a picture of that on the next slide. And then these next two, your CT of like all body or PET scans, you're just doing that for like to see like the extent of it, because obviously again you're not going to be able to feel lymphadenopathy if it's internal, but you'll see it on a scan. And also for staging purposes, generally like we prefer PET scan, it's just a little bit more accurate and easy to see. So yeah, some pictures here to like demonstrate what that looks like. So it's a pediatric PET scan, but it's just showing you where, so like the PET scan, it involves giving like, I know it as like radioactive sugars are given in and they're taken up by proliferating cells. So if you've got lymphocytic proliferation, say here in the mediastinum, that's going to like show up as glowing. So it really quickly and easily highlights to you where you've got this cancerous activity. And in the mediastinal widening, that's obviously only going to be if they've got lymph nodes that are cancerous within the mediastinum or other areas. But I used to think it meant that the rib cage was like, I used to overcomplicate what it meant. It literally just means that, like, where you can see the cardiac shadow there, it just looks wider than it should be. It doesn't mean that the rib cage is widened or anything kind of a little bit scary like that. Then you've got some investigations that you want to do for planning as well, because the unfortunate thing with cancers obviously is that the treatments for them are pretty nasty as well. Sometimes they're going to cause more symptoms than the patient had in the first place, but it's kind of to mitigate the risk of it getting worse. So you want to take a serum uric acid because there's quite a high risk of tumor lysis syndrome, which we're going to talk about a bit closer to the end, because that is quite not common, but it's especially linked to lymphomas. Underlying tests of all your organs, so particularly like cardiac function, like do a baseline echo, especially where cardiotoxic chemotherapy is to be used. Virology, because you want to check these patients don't have anything that if you're immunosuppressing them further with chemo and radio, you're going to make it worse. Electrolytes and renal function, liver function tests, thyroid function, respiratory function, and fertility, because you can get both temporary and permanent fertility problems, unfortunately, with these as well. So like just going into like a little bit more depth on that, generally with like your lower grade cases, so like your stage 1, 2 in your, if you go back to your Ann Arbor classification, you would use like low dosage chemo with a bit of adjuvant radiotherapy, and then chemotherapy, but like much higher doses for your higher grade cases. I've kind of written this out because I'm assuming you guys, some of you might not have done like palliative and stuff like that, and I've just pulled this from like some of the teaching that I had in that. So sorry if I'm telling you stuff that you already know, but generally in chemo, you normally give it IV, and patients will come in for it, say a few times a week over a course of a few weeks, and similar with radio as well. And that's why a lot of patients have these Hickman lines, which I've got pictures of here if you aren't aware what those are. And it just saves you having to like obtain IV access every time you're seeing the patient. Some side effects of chemo to remember, so it's cytotoxic, it's going to attack loads of cells in the body, and as like they can make it as specific as they like, it's going to cause these. And like obviously there's that characteristic hair loss, mouth ulcers, tiredness, skin rashes, increased susceptibility to infection. If it attacks bone marrow, you get your side effects of that, like you're bleeding, bruising, because you're missing your platelets. And then with radiotherapy, if you're using that, because radiotherapy works by attacking, like affecting DNA replication, so it particularly targets like cells that are proliferating a lot. You get this damage to mucosal tissue and proliferating cells. So, and then later, like they're like your immediate effects, and then further down the line, it tends to cause damage through like oxygen radicals and stuff like that. So sore throat, sore and reddened skin based on like what the treatment area is, nausea and vomiting, dry mouth, loss of appetite. They're like some of your classical side effects that you get of it. So a bit of a case for you guys. I think this would be helpful if I could have it open, but let's see if I can actually have any of you guys. Sorry, I just want to check whether anyone's been trying to chat to me. Right, it's not working, we'll just go back into it. Yeah, I did want to try and do this as a bit of a quiz, but I'll just talk through it. So we've got a 25-year-old Caucasian male who presents to the GP with a slowly enlarging, painless right neck mass. It's been growing quite slowly. He doesn't seem to have had a cold or any fevers, night sweats, weight loss, or any of those like constitutional B symptoms. Seems otherwise healthy. And when you go to examine it, it's about 4 centimeters firm, non-tender, mobile, located in the right anterior cervical chain. And he hasn't got any organ enlargement in the abdomen either. When prompted, he does recall that he had glandular fever in his teenage years. And actually, when he's really prompted, he thinks, yeah, it does hurt a little bit when I go down to the pub for my pint once a week. And his hands have seemed a little bit itchy, but he just put it down to changing soaps and stuff. So I've tried to highlight here what in particular with this case is going to make you think that it is what it is. So this is like a bit of a classical history, or at least a textbook history of someone with Hodgkin's lymphoma. And the reasons I'm thinking this more so than non-Hodgkin's are because we've got a young male. It's been growing quite slowly. So he's not all of a sudden coming and been like, oh God, what's that? The other symptoms where he's talking about the absence of other symptoms / the way it feels on examination, they're quite non-specific to all lymphomas. But the glandular fever history, you're thinking, okay, he's going to test positive, he's going to have had Epstein-Barr virus, which at least in an exam sense you link very closely with Hodgkin's more so than non-Hodgkin's. And this idea of like the alcohol pain thing, that in practice doesn't really happen a lot, but in exam questions, like if any of you have been on PassMed and you've been seeing this, they do love to like bring that one up quite a lot, and that tends to be linked more with this than it does with non-Hodgkin's lymphoma. So yeah, non-Hodgkin's lymphoma, it's an uncommon hematological malignancy of mature B cells, and you get these characteristic Hodgkin cells and Reed-Sternberg cells. So anywhere that you see Reed-Sternberg cells, instantly think Hodgkin's lymphoma. But in order to be able to see those, I've like included a picture of what they look like. Again, you should never get given a picture of that in an exam and actually get asked to ask what it is, because you just don't need to do that unless you actually are a hematologist. But yeah, you need to take a biopsy and it's going to have to be sent to a lab for analysis. It's not that common. Somehow like slightly happens more in men, but only ever very slightly. It's got quite good survivability, probably because it's a cancer of the young. So it tends to peak in about the 20s or 30s. Risk factors for it: Epstein-Barr, previous infection with, bit of an association with family history and HLA types. There's like some evidence to suggest that certain occupations and environmental exposures do increase your risk, but there's not very strong evidence for this like at all. And the WHO have like broken it down into classical and nodular. So classical is your Reed-Sternberg type, and then nodular has these things called popcorn cells. So I doubt that would ever get brought up, but if you ever see the word popcorn, that popcorn cell still comes under Hodgkin, but they tend to just go with Reed-Sternberg. So like features, again, you're going to get sick of hearing this rubbery feeling, painless cervical lymphadenopathy, but that is what most patients, if anything, are going to present with. And there's mass effect symptoms if the lymph nodes are elsewhere. Also, it could present more rarely with generalized disease, those B symptoms, or hepatosplenomegaly, but not as commonly, and pruritus as well. You may get this alcohol-related pain, which tends to be like a bit of it's described as like being an ache when people drink or around the period of time that they're drinking, but again, it's quite a vague thing. And something that's also rarely associated with it, more so on paper than in reality, is something called a Pell-Epstein fever, which it's only ever referred to as a Pell-Epstein fever when in relation to Hodgkin's lymphoma. But it's a cyclical 2-week fever of like gradually increasing temperature, gradually decreasing, gradually increasing. You get it as well with things like malaria sometimes, but Pell-Epstein is specific to Hodgkin's lymphoma. Yes. And the management, similar to what we talked about with the general management for lymphoma on a whole, supportive, symptomatic, mainstay chemotherapy with a little bit of radio if it's lower grade, and you use something called the ABVD regime. I wouldn't worry too much about like remembering that. It wasn't something I ever bothered to learn, but it could be a useful thing to know if you can hold that level of detail in, and use about 2 to 4 cycles of it. So it's ABVD because it's doxorubicin, bleomycin, vincristine, and dacarbazine, if you're interested. And in stage 3-4, it's mainly just chemo because you want to be like firing higher strength drugs at it and hope it'll get rid of it. And you do about 6 to 8 cycles of the same regime. And where that fails, you'll use more experimental approaches like immunotherapy. If you've got high risk cases, you're just going to continue to follow them up with like oncology checks, full blood count, biopsies, etc. And the things to be worried about here as well are like secondary malignancies, and then the side effects of your chemo, like heart disease and lung disease. So yeah, that is Hodgkin's. Second case, this time we've got an older gentleman who's presenting to the GP with worsening dyspnea, night sweats, fevers, bilateral axillary lymphadenopathy. So he's noticing nodes in a few more places, a slightly more like disseminated presentation. And over the past 3 months, he's gone off his food quite a lot, and he's dropped a gene in the shirt size. And when you examine him, you notice he's got this axillary mass on his left-hand side, feels very similar to the patient in the last case. And also he's got palpable splenomegaly. So if it wasn't quite obvious, because there's only really the two types of lymphoma, here we're talking about non-Hodgkin's lymphoma. And the things that are making me think this is non-Hodgkin's over Hodgkin's, in this case, I've highlighted again for you. So that would be the fact that it's an older man. He's got these B symptoms, which actually, like, they're more common in patients that are, again, like a little bit either later stage or just older. And the palpable splenomegaly, you tend to associate that, again, at least in an exam questions scenario, with non-Hodgkin's over Hodgkin's lymphoma. So non-Hodgkin's, actually, like, it tends to just be what we lump everything that isn't Hodgkin's into a group of. So there's loads of them. I've focused mainly on 3 types in the next slide, because you don't ever really, like, tend to hear mention about other ones, but there's, like, loads of different, like, weird and wonderful ones. The incidence of it has gone up a little bit. So it's more common, obviously, because there are more of them than Hodgkin's lymphoma is. But it's still, like, on the grand scheme of cancer, still quite not the commonest. And we subclassify it by grade, which is low or high, but we'll get onto that in the next slide. So risk factors for it, like we said before with the case, just being older, being a guy for whatever reason, previous immunocompromise, past infection. So yeah, there is still a link with Epstein-Barr and this, but it's not quite as tied. It's more associated with 1 or 2 subtypes, whereas Epstein-Barr is associated with Hodgkin's lymphoma as a whole. And also, like, H. pylori, that can link to, like, those moltomas you can get in your gastric tract, if you've, like, read up about those at all when you've been doing GI. And there's, like, certain familial cases, familial syndromes that have a bit of a increased tendency to get this, like Wiskott-Aldrich, and ataxia telangiectasia. Agricultural work, for some reason, I think that's, like, the occupational exposures thing with Hodgkin's. Like, nobody really knows why. It's just in a few places where I've been kind of doing my reading for this. So usually painless lymphadenopathy is how it presents, or you might have those mass effect symptoms, and splenomegaly and the kind of resultant abdominal discomfort, because that's obviously pushing everything else to one side, is more common with this. And you might get skin manifestations with this as well, but that's not particularly common. So we grade this into either high grade or low grade. You sometimes see this referred to for, like, lymphoma on the whole, but this generally just refers to non-Hodgkin's when you talk about this grading. And if something's high grade, it means there's more proliferation, really quick doubling time, and the diagnosis might come in a matter of weeks. And it's generally more life-threatening, but it's a lot more highly treatable, because if you think about the way your radiotherapy and your chemotherapy are going to target rapidly proliferating cells, it's easier to target, but it is more dangerous. But then you also have low grade, which divides more slowly. It can be there for a long time before the patient really, like, does anything about it. But on the whole, it's not as curable, because the cells aren't proliferating as quickly. But we tend to manage it a lot more expectantly than by actively doing anything to begin with. So, like, management very similar in terms of chemo and radio regimen as it is for Hodgkin's, but you use something called the CHOP-R regimen if you wanted to remember what drugs go into it. So that's cyclophosphamide, doxorubicin, vincristine, prednisolone, and rituximab. Rituximab, if you're going to remember one drug out of all this, remember that one. And it's like, it targets CD20 plus or something receptor that's only on the B cells, so it doesn't work on the T cell variant. And you're going to continue that for, out of all that regimen, you're going to continue that for 2 years, because I guess because that's the most effective drug in the lot. I'm not really too sure, I'll be honest. So bit of a case for you. Like, I think when I've done past paper questions where non-Hodgkin's came in and they really wanted to, like, break down the types, this was really, like, the only type that I really remember seeing, because we're going to get onto the subtypes in a second. So you're a doctor working out in the Democratic Republic of Congo. You see this 13-year-old girl who's got a massive growth in her neck, and then she's got resultant dyspnea and hoarseness. And it's been slow growing for quite a long time. She hasn't really got any other symptoms, but she's recently been known to have been a malaria sufferer. So this is, like, a particularly unique type of non-Hodgkin's lymphoma called Burkitt's lymphoma, which, like, out of the rest of them is, like, it's just the most identifiable. And they quite like it in exam questions, because it's generally, like, there's what you call the endemic type, which is found in equatorial areas of Africa where malaria outbreaks are known to be. Does tend to also be linked to Epstein-Barr, and it tends to be young people that have these, like, massive jaw tumours. And it could be that they're massive because they're just not treated for ages. It could be that they're massive because that's just how that tumour type tends to go, because they like proliferate so rapidly. But the most common of the non-Hodgkin's lymphomas is diffuse B-cell, and follicular is the second most common. So I think I've seen fussy little questions sometimes where it asks like, okay, this patient who is like a Western person in a GP presents, what type are they most likely to have? It will be diffuse B-cell. If you're talking about the young child that's out somewhere in sub-Saharan Africa, it's going to be Burkitt's lymphoma, for instance. And you've got all these like other less common types, which probably aren't really worth thinking about too much, but like just be aware if you find a mention of a lymphoma that has a really weird name, it's probably going to be a non-Hodgkin's subtype, and then you can probably like apply your knowledge of that to that roughly. Okay, I think this is the final case I've got for you guys. So we've got a 23-year-old girl who's recently been diagnosed with a bulky, quite widely disseminated stage 4 non-Hodgkin's lymphoma, and she's been started on the correct regimen of chemotherapy and underwent her first course 24 hours ago. She presents to A&E with a sudden frequent episodes of nausea, vomiting, diarrhea and lethargy, which has now progressed to dyspnea and faintness. On examination, she appears visibly dehydrated, confused, tachycardic and hypertensive. And when you get a blood sample from her, it demonstrates that she's got elevated uric acid, potassium, phosphate, as well as creatinine and urea. So I don't know if everyone was like paying that much attention. A while ago, I talked about something in particular that happens quite a lot, or at least on exam questions, quite a lot with lymphomas, and that the slides aren't going how I want them to. It's tumor lysis syndrome, basically. So you might have read about this already. You might have something about this in oncology notes, but link it particularly to lymphomas because it tends to happen post chemotherapy or post initiation of chemotherapy with lymphoma. And the things that are making me think that is, okay, right, she's got quite a widely disseminated bulky lymphoma. She's just been started on chemotherapy. She's got all these like signs that are suggesting that even before I see what the biochemistry results are, signs of electrolyte imbalance from like the nausea, vomiting, diarrhea, lethargy, and things like the dehydration that she would get with that as well. So tumor lysis syndrome, again, not that you need to know it. If anyone's interested, included an image that just shows you where like the different preventative drugs that we use, where they act in the pathway. I know for some people that's kind of something that helps them learn. What you tend to have is you get a patient that's initiated on chemotherapy, it causes cell lysis, and then they get this release of potassium, phosphate, uric acid, and then they get this like electrolyte imbalance that has all the resultant effects, whether that be like seizures, syncope, arrhythmias, dyspnea, whatever it is. It's not great and it needs treating pretty quickly. And it is one of the emergency, like it's one of your oncological emergencies. So we particularly associate it with hematological malignancy, especially Burkitt lymphoma. Diagnostic criteria, we're just having at least 2 on biochemistry of hyperuricemia, hyperphosphatemia, hyperkalemia and hypocalcemia. You're more at risk of it if you've got obviously lymphoma, but like large disseminated bulky disease, chemosensitive tumours, so that's dependent on like what markers the tumours have, and having recently initiated chemo. Like it's quite rare for it to happen after you've been going to chemo for a while, but you can also get a presentation of it where the case that we had just then was obviously someone that had just suddenly had it. Sometimes it can be like built up over a few chemo sessions. So to investigate it, you're going to get serum electrolytes, looking for like that hyperuricemia, hyperphosphatemia, etc. Do an ECG because obviously you're worried about that cardiac function in this instance. And to manage it, you can prevent it by making sure the patient's quite well hydrated before you initiate chemo. Consider phosphate binders, allopurinol or rasburicase. I've highlighted rasburicase because obviously allopurinol we use in other things as well. Rasburicase I used to kind of, like if I saw that I used to think, okay, that's tumor lysis syndrome. And I think it's preferred, but I guess it depends on like where you're working would rather you use. Loop diuretics as well. Acute management, obviously like treat any cardiac arrhythmias or seizures, intensively fluid resuscitate them, use rasburicase again. Okay, so that's it. So rasburicase you can use both in prevention and in treatment, and correct any hyperkalemia. And in worst case scenario, especially like to correct the potassium and stuff, just go straight for renal dialysis if you have to. Right, I think that's everything I've got for you guys on this. So if I can get up your questions, if it'll load for me.